GER and the GERD, or the Gastroesophageal Reflux and Gastroesophageal Reflux disease. So before anything else, what are the contents of this? The contents of this is the definition of the disease, causes or risk factors, assessment findings about the signs and symptoms, diagnostic test, medical and surgical management if applicable, nursing interventions and family educations and health maintenance. So, what is the definition of GER and the GERD? The gastroesophageal reflux is the passage of gastric contents into the esophagus. The barrier between the stomach and the esophagus is controlled primarily by the pressure at the lower esophageal sphincter or the LES. The gastroesophageal reflux disease or GERD is defined as the symptom complex that results as a complication of GER. What are the cause and risk factors? Cause is undetermined in most patients. However, possible causes may include delayed neuromuscular development, cerebral defects, obstruction at or just below the pylorus. Example for this is the pyloric stenosis and malrotation, physiologic immaturity, increased abdominal pressure, obesity, cystic fibrosis, and congenital esophageal disease. Associated conditions that contribute to reflux include chronic lung disease, trauma or mechanical causes that affect the LES. Studies shows a reduced incidence of reflux in the prone position versus the supine position, protein allergy, medications or drugs that affect LES and increase gastric acidity, cystic fibrosis, cardiac disease, and other chronic illnesses. Assessment findings, signs, and symptoms. For infants, vomiting or regurgitation of formula or breast milk, irritability, excessive crying with or without associating with vomiting, sleep disturbances, arching, stiffening. It is recommended that the infant be referred to a pediatric gastroenterologist. Intermittent vomiting, chronic heartburn or regurgitation, upper abdominal discomfort or the pressure or squeezing feeling, chronic respiratory airway symptoms such as cough, stridor, otitis media, bronchitis, and asthma, food refusal, dysphagia or the difficulty of swallowing, adenophagia or the painful swallowing, anemia from the chronic esophagitis, hematemesis, hypoproteinemia, and occult blood in stool. The diagnostic test. First is the history and physical exam can diagnose most cases. Multiple intraluminal impedance and esophageal pH monitoring can be performed on all ages. Endoscopy and biopsy allow for visualization of esophageal gastric and duodenal mucosa. Technetium scintigraphy or the milk emptying scan is to assess gastric emptying and associated aspiration. The modified barium swallow, also called video fluoroscopy. Esophageal manotometry to measure the pressure inside the LES. Next is the intraluminal esophageal impedance to detect the flow of liquids and gas through the esophagus may be used in combination with manometry. 8. Polysomnography may be used for the evaluation of infant apnea and sleep apnea.
And next up is the medical and surgical management. For the medical management, first is the positioning for GERD, feeding for GERD, feeding for GERD, other lifestyle changes for GERD, and drug therapy for GERD. And for the surgical management, Nissen fundoplication is the most commonly used surgical method to treat moderate to severe GERD that is unresponsive to medication therapy. Decisions concerning appropriate long-term feeding access must be individualized. So in the picture shown is the view of the stomach after the surgery. And now for the nursing interventions. First is preventing aspiration, maintaining adequate nutrition, maintaining fluid and electrolyte balance, and reducing fear of eating. In preventing aspiration, administer medications via IV line until tolerating enteral feedings, maintain positioning, use cardiac and apnea monitors for infants and children with severe reflux, and lastly is to provide chest physiotherapy before rather than after meals and if ordered. Nursing alert, avoid slouching position because this may change angle of esophagus in relation to stomach, increase intra-abdominal pressure, and facilitate reflux of stomach contents. For maintaining adequate nutrition, first is to provide concentrated formula if volume cannot be tolerated, seek nutrition consult if patient continues to have difficulty in feeding, Monitor for fatigue during feeding. It increased effort to suck requires higher energy expenditures. Monitor weight on the same scale. Accurately record activity of the infant. Explain to the breastfeeding mother that the feeding modifications may need to be made. Follow post-operative instructions on initiation of feedings. If the child has a GT, usually elevate an event until return of bowel function. Monitor drainage, avoid kinking, and follow orders for positioning for straight drainage, elevation, or clamping. For maintaining fluid and electrolyte balance, first is to monitor vital signs and assess skin turgor for signs of dehydration, observe and record accurately urine output, monitor IV therapy if ordered, monitor serum electrolytes, magnesium, phosphorus, and calcium, replace as ordered, and promote good skincare to prevent lesions of dry and delicate tissues. Nursing alert if patient is malnourished. Monitor for refeeding syndrome until laboratory studies are stable. Refeeding syndrome can cause intracellular shifting of electrolytes, including calcium, magnesium, and phosphorus, resulting in death. And for reducing fear of eating, first is to provide thickened feedings to increase satisfaction for the infant. Identify and attempt to reduce stress, especially around mealtime. Feed the child in a quiet and calm environment. Children like routines, and feed at routine intervals by the person with whom the child is familiar and comfortable with. For the older child, encourage the participation in family dinner time so the child observes eating as a pleasurable experience. And lastly is to advise the parents that clinical specialists in feeding disorders are available. Family education and health maintenance. First is plan a program of intensive parental teaching on how to handle and care for the infant. Second, if infant or child is not demonstrating complication of GER or GERD, assist parents in understanding that GER is self-limited. Symptoms usually disappear within 12 months. Third, if complication exists in GERD, referral to pediatric gastroenterology and nutrition specialist is recommended. And fourth, if Nissen fundoplication has been performed, first is to teach gastrostomy care if applicable. Next is to explain about the potential complications and when to call the healthcare provider. It usually takes 12 weeks to heal, and if the GT becomes dislodged in this period, the patient should be taken to the emergency department immediately. Next and lastly is the complications of a dislodged GT in the early postoperative period include peritonitis and bacteremia. Fifth is to help the parents understand the importance of follow-up for assessment of weight gain and development. Sixth, assist with community resource planning, such as e.g. education advocacy and financial assistance. Identify support groups. Seventh is to instruct parents and caregivers in CPR training before discharge of infant if indicated. Eighth is to provide written and verbal instructions for medications and adverse effects. Ninth is to advise the parents on when to call the healthcare provider in regard to their child's symptoms. 10th and lastly is to encourage the family to contact their healthcare provider immediately with treatment concerns or problems. And that would be all for our presentation. Thank you for watching.